Okay, so thanks for being on time. We're now starting with our first lecturer today, and therefore I'm delighted to introduce you to Dr. Otmar Schindler, who has studied medicine here in Graz and is now working as a specialist in pulmonology and intensive care medicine. He's also got many years of experience as an emergency doctor. Today he's going to introduce us to lung sonography and sonography regarding the diagnostics of deep venous thrombosis. We're delighted to have you here once again at one of our late summer schools. Please give a warm welcome to Dr. Otmar Schindler.
Hello, thank you for inviting me here. Thank you for the warm words of welcome. Hello to everybody out there at the screens. I'm going to talk about the dyspnoeic patient, the lung and DVT ultrasound. In fact, most of you know everything about lung ultrasound because you have used it in the EFAST exam. So usually there's not so much I can tell you, but perhaps I will sometimes make the link to the clinical patient that you see that presents to you in the emergency room in the intensive care department in the paramedic situation. So let's just start. And a big thank you to Peter Zechner. I'm not used to that. Peter Zechner, I got nearly all the slides from him. He's already also been presenting at the summer school already, and he's in fact the authority of lung ultrasound in the city of Graz. So if anybody wants to know something about lung ultrasound, go to the LKH Graz West, or next year LKH Graz 2, and ask him. He's very kind and he always explains everything you need. Why do we talk about lung ultrasound? What does the dyspnoeic patient have? If you encounter a patient who comes to you and is breathing heavily, what are the things you immediately think about? There are the big 5 and one more reasons. The first reason, for me as a pulmonologist, is always bronchial obstruction. Most of them have COPD or asthma. It could also be pneumonia. Winter time is coming, so perhaps the patient who is breathing heavily, who is coughing, could have pneumonia. Pneumothorax is rather something you don't see so often, but if you see it, sometimes you have to react quite quickly. And I'm speaking here mainly of the pneumothorax that is not non-traumatic, so spontaneous pneumothorax or secondary pneumothorax. Pulmonary edema, of course, it's a big differential diagnosis, although in most cases it's not a pulmonary disease. Doesn't matter, the patient comes to the doctor, patient is breathing heavily, the patient is in distress, so you just have to react. And there is one thing that is not among the big 5, but still you should think about it, the pleural effusion. A pleural effusion that makes heavy respiratory distress is rather a rare condition. It can happen in the patient with decompensated cardiac failure, so perhaps he should also have pulmonary edema, and it happens in malignancies, but in malignancies it's not that acute often, yeah? So it's becoming worse and worse, and once perhaps it's getting the patient into distress. But that's not the acute care setting where you see that. And as you can see, most of these conditions you can diagnose with ultrasound. So whenever you're thinking about a patient who is in respiratory distress, use the ultrasound probe. Just grab it and use it. And if you don't find anything, it's quite likely that it will be bronchial obstructive disease. Because if you don't see anything in the ultrasound, and still it's one of the frequent reasons for respiratory distress, it could be bronchial obstruction. You see that X-ray? Hands up for those who think the chest tube that's inserted here is for pneumothorax. And hands up from those who think it's a pleural effusion. Why is this chest tube inserted? Pneumothorax? Pleural effusion? It's both. You can have both. You don't see it on the X-ray. Why? X-ray is a two-dimensional image. And two-dimensional images always have a problem. You don't see everything. What does William do here? He's just telling you he got his 3rd child. Always look to the 2nd dimension. And it's much easier to have the 2nd dimension if you have the ultrasound probe in your hand, you just slide it on the thorax. With the X-ray, you have to either rotate the patient or rotate the X-ray machine. It's not so easy, and still you have a compressed picture of the thorax. So sometimes ultrasound might be better. I'm talking a bit about the basics of thoracic ultrasound. What do we see? Why do we see something? Why don't we see so much? And then about the pathologies themselves. Ultrasound basics, that's a CT scan. If you take your ultrasound probe and you put it here, what will you see? Lots of thoracic wall and not much more. Yeah? If you put it here, you will see the shadow behind the rib and nothing more. If you put it here, you will see the chest wall and then perhaps some motion, but you don't see the lung. You never see the lung. Why don't we see the lung? Because, as we all know, ultrasound is not very good in penetrating gases. It's reflected. And the lung is full of gas, it's full of air. So as soon as you have the lung healthy and full of air, you won't see anything. What you see is if there is fluid in the lung or if the lung gets consolidated. If you want to see something that's inside of the lung, you need an acoustic window. Either you have it because you have fluid there, the pleural effusion, and behind the pleural effusion you can see something. Or you have a consolidation that reaches the lung surface, so you can see everything that's attached to the lung surface. And sometimes you will have an atelectasis, and behind the atelectasis you see some pathology. So again, you need an acoustic window. You need a point where the ultrasound beam can enter. Here it can enter. Here you don't see anything, if it's just the healthy lung. So the first thing we have to have in mind, if you see the lung is not healthy. There's something wrong with it. And that's a great advantage of thoracic ultrasound, of lung ultrasound. As soon as you see something, you know there is a pathology. If you don't see anything, the lung could be healthy. So what we see is mainly artifacts. And there's one special thing we see. It's if there's a change in impedance, there's an artifact called the B line that we will discuss in a short time. If you take the ultrasound probe in your patient with respiratory distress, you just take it in a longitudinal way on the front of the thorax. And what you immediately see is here one rib, here the other rib, and between the ribs there is a thin line. It's called the pleural line. It's not the pleura itself, in fact. Yeah? It's just an artifact of the reflection of the lung surface. Behind the ribs you have the shadow. And if this is healthy lung, behind the pleural, the so-called pleural line, what do you see? Nothing, just artifacts. You don't see what's happening inside the lung. You just see the artifacts of the reflection at the pleural line. So if the visceral and the parietal pleura are moving with every respiratory cycle, you should see this so-called lung sliding sign. Yeah? Lung sliding you see here at the pleural line. It's working or not? Sorry. No. You see here? Should see here the motion of the lung against the thoracic wall. If you see that and nothing more, that means healthy lung at that spot. So if you see this, there is a motion. The lung is in contact with the thoracic wall, and you don't see anything behind, so perhaps it might be healthy lung. If you do that in M mode, it's the so-called seashore sign, because some innovative people thought that looks like a seashore. I don't think, but can imagine there are the ocean and the waves coming towards the sandy beach. Yeah? That's what they think it should look like. So the important thing is you have a change here where the pleural line is. Outside the pleural line, nothing is moving in M mode, yeah? Because the thoracic wall is not moving normally. And behind the pleural line, there is a motion. There is the lung artifacts, in fact. It's not the lung that you're seeing, and that's moving, so you have a moving picture there. The second thing I want to tell you, and most of you might know it, is the B lines. What are the B lines? The B lines are just an artifact that arises at the moment where there is a heavy change of impedance. So the ultrasound beam is entering the thorax, and usually it's absorbed in the moment where it's rejected, the moment where it contacts with the air. The problem is if there is not only air but some other things inside, like for example water, like for example interstitial tissue, it gets reflected and reflected and reflected, and it makes a laser beam-like artifact towards the end of the screen that's moving with every respiratory motion, because it arises from the visceral pleura. So as soon as you see a B line, you know there is visceral pleura there, because it's starting at the visceral pleura. You know there is motion there because the B line is moving usually, and you know there is too much of anything inside the lung. In our conditions, mostly it's too much water. It could also be too much tissue. So it's usually pulmonary edema, or other possibility, lung fibrosis. That's where you often see it. You also see it in ARDS because there's too much water in the lung, for example. Yeah? Okay. And that's the moving of the B lines. The B lines going towards the end of the screen, arising at the visceral pleura, moving with every respiratory cycle. So that's what the B lines are like. And if you see them, you recognize them. There was a study conducted in Italy some 10 years ago or something. They had an ultrasound veteran from the radiology department and a student who has never had an ultrasound probe in his hands. They showed them the B lines, and then they put them, they showed them pictures, and they had, they showed them patients, and they had them count the B lines. And they had the same results. Because the student who did it the first time, after an introduction of 2 hours, just knew how to do it. It's not very difficult. Yeah? And that's the good thing with the lung ultrasound. It's not so difficult. So we said the problem with the lung is you have gas, fluid, and solid things. As long as you have fluid, you have to recognize it. How do we see fluid? Usually in echo. What does fluid look like? Just black. So the black thing is the fluid here. No rejection of the sound. Inside you have some solid parts. You can see them only because there is fluid, so that excludes pneumothorax, for example. And inside the solid part, you see some heavy reflections in white. What's that? Gas. So which gas usually? Air. That's all. It could also be gas in an abscessus, for example. But in this picture, it's just air. Why is there air inside? That's the bronchi. That's bronchogram. Okay. We are working mainly with artifacts, we say. We don't see the lung, we just see the artifact, so we see if it's pathologic. So this is a picture from Venice where I just was last 2 days. What's the difference in these two pictures? It's taken at the same moment from the same point. Is there a difference? It was taken with the iPhone, there's no exposure time. It's the focus. You can do that with the iPhone. Put another focus. If you see here, sorry, I'm not used to this. Not working so well. On this picture, you can see the stairs here, yeah? This picture, you don't see the stairs, but you see the bricks. You see the bricks that are here. So you have to point where your focus is. And that's something that's very important with thoracic ultrasound. As you are working mainly with artifacts, you have to know your machine. You have to turn the gain on and off. You have to position your focus, because if you want to see a pneumothorax, it's not good to have your focus in 10 centimeters depth, where nothing is happening except artifacts. So you have to position your focus. You have to know your pneumology. So in fact, to see how you turn up your machine, so you have the best information from your artifacts that are arising. So the pathologies that you see when you go to a thorax, I'm mostly speaking about non-traumatologic pathologies, but one thing that I don't know if you have already talked about it during the summer school, that's quite important, it's quite easy, it's the rib fracture. Whenever a patient is coming, he had a trauma or he had an episode of heavy coughing, and he says it's hurting here exactly, and you point your finger there and he says, hurting. What do? Immediately, you don't send him to the radiologist. Radiologists, they miss the rib fractures. It is not because they are bad, but it's just because X-ray is not good for detecting rib fractures. So you just put your ultrasound probe there. So, okay, it's a bit difficult with that pointer. And you see here the rib, and here there is a little step, and then again the rib. The black thing you see here is the hematoma from the fracture, and down below the rib, you see, what is it? Lung sliding. What does lung sliding exclude? Pneumothorax. And what's our biggest fear in broken ribs? Pneumothorax. The second big fear is what Aidan mentioned. The lung can have a contusion. Lung can be bleeding. There could also be hemothorax or something. But in fact, you just see you can exclude the pneumothorax at that point, and you see the rib fracture. You have your diagnosis. So if there's a rib broken, what is the next thing you do? You point your probe one rib upwards and one rib downward, because usually it's not only one rib that's broken. So just with a single method, takes about half a minute, you can diagnose this patient. You don't need anything more, in fact, yeah? So that was everything about rib fractures. If there are any questions, just start, yeah? Next thing we're talking about is the water, so fluids, pleural effusion. There's not much to say about it. You know what it looks like. It's echo-poor or echo-free sometimes, yeah? It's between the pleural layers usually, and frequently there is a consolidation inside, because either the pleural effusion is the result of some pneumonia, of some pathology that's going on in the lung, or the pleural effusion is compressing the lung, so compression atelectasis. You can detect pleural effusion quite easily with ultrasound. You have the same detection rate as with the computed tomography, and it's much, much, much better than with chest X-ray, auscultation, percussion, or something like that. Yeah? Which probe do you use? We always said you have to take the right probe and take the right gain and instruments. You could use any probe, in fact. Yeah, you can also detect pleural effusion with a linear probe. The problem is you don't enter far enough. So if you want to see how big is the effusion, how much is there something in the effusion, it's rather good to take a probe that gets a bit deeper. So you could use either the cardiac probe if you just have it in the hand because you're examining a patient, or you take the abdominal probe or a microconvex or something. Yeah? So that was taken with a classical convex probe. What do you see? An effusion. This is the diaphragm. So below is in this, I think it should be left side, so it's the spleen. And upwards in the effusion, you see nothing. And at the upper end of the effusion, you see the lung coming in, yeah? So lung is still just reflections, nothing more. Another picture there, you have something inside pleural effusion. It's an adhesion, apparently. And there also you see some granular structure. If the effusion is older, there's some proteins, some fibrin that's getting inside, so sometimes you see some structures. It could also be, if it's a fresh hemothorax, it could look like that, yeah? So it's getting more and more and more echogen with the time. Does this patient have pleural effusion on the left side? Yes or no? It's again, the supine X-ray is not very good to detect anything. If you put your probe there, you see, in fact, he has a bit of effusion, yeah? But his real problem is an atelectasis. Yeah? It's the consolidation here. Do you see the effusion? You see the consolidation. If you watch a DIT picture, you don't know how big is the effusion, how much consolidation, what's really going on. So in this patient, and that's what's happening to me every time. That's a patient on my intensive care unit. I have him. I don't have a CT in my hospital, so I can either put the ultrasound probe there or just guess what he's having. Yeah? Okay, question for pleural effusion? Nah, it's quite easy, I think. Yeah? Next thing, big thing is pneumothorax, and all of you already know a bit about it or know a lot about it. For pneumothorax, you should use the linear probe. Why? Ideas? You just go until the pleural line. You don't have to go deeper because you don't see anything behind it. Yeah, it's enough. You take the supine position. Where do you put the ultrasound probe? You just start here. If the patient is supine, you should start on the point that's most upwards because the air in the pneumothorax is just going up. So if your patient is in another position, you would see the air here, but you can't screen the lung apex so good. So if you put him in 30 degrees up position, the air will collect here. It's easier to get. And if he's really supine, it can be anywhere here on the front. Yeah, you just put your probe where the lung should, where you expect that there is no lung in case of pneumothorax. How do you see a pneumothorax? The first thing is you don't see the lung sliding anymore. Lung sliding is the visceral pleura going versus the thoracic wall. If you don't see the lung sliding anymore, there's something going on. The second thing is, as soon as you see a B line, there cannot be a pneumothorax there. Why? Because the B lines are arising from the visceral pleura, and if the visceral pleura is there, there's no pneumothorax. And the third thing that sometimes you can see is the lung point. If you see the lung point, and we would see that in detail, then you can say with 100% specificity there is pneumothorax. What does it look like? That's a healthy patient. We have seen that there's lung sliding. In M mode, there's the seashore sign, as it's called. Yeah? And that's the patient with pneumothorax. You don't see here in the pleural line, you don't see the motion. There is a bit of a motion in the picture. That's because the patient who is in respiratory distress is breathing deeply, and you can't hold your probe that still, that you don't see any motion. Yeah? But the motion is in the thoracic wall as well as anywhere else, but there's no motion here where you expect the pleural line. And if you put the M mode in, there's no seashore anymore, or there's no beach anymore. Yeah? There's just the lines. That's the stratosphere sign. Okay? So if you have, sorry, that was the case of of abolished lung sliding. Next thing we have to see is if there are B lines or not. If there are B lines, like here, you can exclude pneumothorax, although the lung is not moving here. Why is the lung not moving? Is there a proper lung sliding here? Sorry? Is that the proper lung sliding? No, not really. So there's no lung sliding, but still there's no pneumothorax because there are a lot of B lines. That's pulmonary fibrosis. In pulmonary fibrosis, if the lung is so stiff, it's not moving a lot, yeah? Especially in the basal compartments. It's not much motion. So you won't see any lung sliding, but you see a lot of B lines, and that excludes pneumothorax at that part, at that region where you're scanning. This is classical pneumothorax. Sorry. This is classical pneumothorax because there's no lung sliding and no B lines, but there's no lung sliding with B lines, so that excludes pneumothorax. And the third thing is the lung point. What is the lung point? The lung point is that point of the thorax where the lung comes in contact with the thoracic wall. So it's, in fact, the end of the pneumothorax. If you have this patient here with a severe ARDS, apparently, he has pneumothorax here, he has consolidations here, and somewhere here, the lung comes in contact with the thoracic wall, and then there is the pneumothorax starting or ending, however you want it. If you scan here, you will have pneumothorax, yeah? No lung sliding, stratosphere sign, clear signs of pneumothorax. If you put your probe a bit backwards, where the lung comes in contact with the thoracic wall, you will see this sign. So here there is no motion, no lung sliding, this is pneumothorax, and here you see the lung sliding, and it's coming in with every breath and going out. That's the lung point. If you see that, you can be sure you have detected pneumothorax. Do we always find the lung point? No. would be too easy, huh? Again, lung sliding versus no lung sliding. You see on the left side of the picture there's no lung sliding, on the right side there's lung sliding, and if you put the M mode in, you see there is the stratosphere sign, or it used to be called the barcode sign. Shouldn't be used anymore, because if you have a flight ticket nowadays, you know what the barcode looks like. It's not so straight anymore, yeah? So it's called stratosphere sign now, and the other thing is the seashore sign. And altogether, there's a consensus statement that says lung ultrasound accurately rules in the diagnosis of pneumothorax. So if you have lung ultrasound, you have typical signs, you can be pretty sure that pneumothorax is there. And also, if you have clear signs that there's no pneumothorax, it accurately rules out the diagnosis of pneumothorax. So in fact, it's quite specific, it's quite sensitive, and has a sensitivity and specificity near 1. Yeah? So you should use lung ultrasound if you are looking for pneumothorax. The one thing that's a problem is this patient. Yeah? See that? Totally collapsed lung on both sides. You won't see anything. You just see stratosphere sign, you just see no lung sliding anywhere. You don't know what's really happening. So sometimes the X-ray is quite cool, but in most cases you will be able to rule out or rule in pneumothorax with lung ultrasound. And what's also a problem with that patient, and much more easier with that patient, if you are suspicious of a pneumothorax, just compare it to the other side. If you're not sure, seeing pneumothorax takes a bit of experience. So if you see this patient and you're not sure is there something moving or not, just put the probe on the other side and you see there is a clear difference. That's what lung sliding looks like in this patient. There's no lung sliding. You compare it and you know there is pneumothorax on the one side. Okay. So, okay. The problems with assessment of pneumothorax in sonography is you don't know the size. You can approximately assess the size if you see the lung point. You can say there's a lung point here, there's a lung point here, so between them there's a small pneumothorax. If you don't see any lung point, if you just see a stratosphere sign, you can say, okay, perhaps it's a big pneumothorax, but you don't see how much air there's between the thoracic wall and the lung. Because as soon as there is reflection of the beam at the beginning of the pneumothorax, you don't see anything behind it. You just see the artifacts. You don't know how big is the pneumothorax. And the other thing is always pleural adhesions. Yeah? You've already seen what it looks like in the case of pulmonary fibrosis, where the lung is not moving a lot. And sometimes after, for example, thoracic surgery, the lung is directly attached to the thoracic wall. You don't see any lung sliding, but still the lung could be there. So after thoracic interventions, could be a problem to see it, also with malignoma, but the malignoma you would see it itself. Okay, so it's not perfect, but it's quite good, let's say. Next thing to see, pneumonia. Is pneumonia useful for the use, is ultrasound useful for the detection of pneumonia? It is, yeah. There's been quite some good scientific work on it. What's the first thing you do if there's a patient coming to you during the winter time? He's coughing, he's febrile, he's breathing heavily. You're taking the ultrasound probe. Huh? What do you want to know? You want to exclude pneumothorax. You want to exclude pleural effusion and empyema especially. Yeah? You want to see what's going on. Huh? Perhaps it could be endocarditis, it could be everything. Yeah? You take your probe and you just scan a bit, yeah? And you see what's going on. And sometimes you could find pneumonia. So if you're suspicious of pneumonia, just try it. Yeah? Which probe should you use? Usually we use the abdominal probe because you have to see a bit into the deep, into the depth. And on the other side, you can easily scan the thorax with that. Yeah? What do you see in cases of pneumonia? The first thing, the pneumonia has to reach the thoracic wall, or at least the visceral pleura. If it doesn't go that deep, you won't see anything. Yeah? It's the problem. So central pneumonia that's not reaching the thoracic wall, you won't see it. It's one of the limitations. But as soon as it's going far towards the thoracic wall, you see there's consolidation. Yeah? There's no air, there are no artifacts, there's consolidation subpleurally, could be big or small. Mostly they are polygonal, they can have every shape in fact. Yeah, they're small ovaloid, every shape is possible. Yeah? Pneumonia doesn't have fixed shapes. The margins are not very clear, so towards the depth you don't know where it ends. In an atelectasis, often it's sharply confined. You see, tuck, tuck, it starts there, it ends there. With pneumonia, in most cases, you don't see where it starts and where it ends. It's moving breath dependently because it's just part of the lung. It's inside the lung is moving, so it should be moving. You can see an air bronchogram. It's not obligatory, but sometimes you see it. An air bronchogram is nothing else than the reflection on the bronchi, like here. Could be here like a tree-like pattern sometimes, or just some lenticular white spots. So typically that's the air inside the bronchi. And sometimes there's pleural effusion together with the pneumonia. You don't have to see it, but sometimes you can see it. But if you have pneumonia or you have a diagnosis of pneumonia, you should always look to the lung basis. You should look if there is an effusion and if the effusion looks clear. And then there's the perfusion that's usually increased. So just take a Doppler mode, it's no problem. And if you have good perfusion, also tree-like shape, just regular perfusion, sometimes increased. You could also use a contrast media if you want, but you won't do that in the emergency department usually. You can see that's a typical sign of pneumonia. What does this patient have? Pneumonia, no. In fact, it was sent to us for a localized effusion. We took the ultrasound probe and we saw it's not localized effusion. It's big atelectasis. Atelectasis even with some bright spots, so some air bronchogram inside. There is an effusion around it. So that was big pneumonia, post-stenotic pneumonia. Yeah? And as you can see here, with the ultrasound probe, you nearly see the same thing as in the CT. Yeah? You don't need the CT anymore. No, we don't. We do need the CT, of course, but if you have a good ultrasound probe, if you just put it on your patient, you can see quite a lot of things, and you can really diagnose without putting the patient in the CT first. You just can start your treatment and then you see what's really going on, okay? So there is also the consensus statement. There are good consensus guidelines where I think from 2012 about thoracic ultrasound. You should read them if you have the time for it. And they definitely say lung ultrasound is useful to rule in pneumonia. The problem is you cannot rule out any pneumonia that's not reaching the pleural surface. So if you see the pneumonia, okay. If you don't see it, you can't be sure. So it's not the perfect tool for this pathology. But if there's a patient coming to you and he's in respiratory distress, he's febrile, he's coughing, just take the probe and try it. You will see something in most cases. Limitations, as we said, if it doesn't come to the pleural, you won't see it. And the other thing that's a problem is it takes time. So finding the pneumonia, you don't know where it is. In the rib fracture is clear. He's saying, the patient is saying it's hurting here. You put your probe there and you have it immediately. Problem is, if you in pneumonia, sometimes they tell you, or sometimes you could auscultate and say, I think it's on the right side and on the left side, but in fact you have to scan the whole thorax, and then you're not sure if you see something. So it takes time. It can't perhaps not be used in any emergency department anytime. Yeah? So pulmonary edema, that's quite easy and that's quite important. As I told you, pulmonary edema is mainly defined by too much water in the lung, and what we see is the artifact that the water and the water-air interface makes. Yeah? So it's the B lines. In fact, we don't see pulmonary edema, we see interstitial syndrome. So we see there's something going on in the interstitium, and mostly it will be in our patient with acute respiratory distress. It will be pulmonary edema, but sometimes it could also be some other pathology. Yeah? So what do we see? Disseminated B lines on the entire chest wall. where do we scan? Scan just everywhere, huh? But there are 8 specified regions where we should scan. I will show you that. There can be pleural effusion. As I told you, in congestive heart failure, people very often have a little bit of pleural effusion, or sometimes also a bit more. So you can scan for both things. You can see your pathology. If it's rather pulmonary fibrosis, the B-lines will look a bit different. The lung sliding will perhaps be a bit less, and you won't see pleural effusion in most cases, so you can differentiate that normally. And the pleura itself will look a bit different. Yeah? There is a direct correlation between the number of B-lines you see and the amount of lung water. So the more B-lines you see in pulmonary edema, the sicker the patient is. And the quicker you do something for your patient, the quicker the B-lines disappear. So you can really see if your therapeutic intervention is successful. For example, you have a patient with hypertensive pulmonary edema. You give him either antihypertensive drugs, or you give him the non-invasive ventilation. You will see in 5 to 10 minutes that the amount of B-lines is going down. B-lines are really going away, in fact. Huh? So you can see if your therapeutic intervention is successful or not. What probe do we use? I like to use the abdominal probe, but as scanning of B-lines was in most cases done by the cardiologist who had his echo probe in the hands, many people use the echo probe. In fact, it's not a problem. The echo probe and the abdominal probe have been validated for it. I would rather not use the longitudinal probe, although you could do it if you want. So which regions do you scan? You see here the anterior axillary line, the posterior axillary line, and the medioclavicular line, and you just divide each hemithorax into four regions, and you scan these 8 regions on the thorax. Why do we use these regions and not others? One thing is, if the patient is in supine position, you can't scan dorsally. The other thing is, most of us, even if we are sitting here, will have some B-lines dorsobasally. Huh? It's just because of hydrostatic pressure. There will be some B-lines in the elderly even more. Yeah? So if you see B-lines here on the apical and on the frontal region, that means there's really a lot of water inside the lung. So it's more sensitive for severe problems. You scan these 8 regions, and if you have at least 2 regions per hemithorax with at least 3 B-lines per intercostal space, you can say that's interstitial syndrome. So together with the clinical presentation of the patient, that will be pulmonary edema. What does it look like? Yeah. I think everybody who sees it will recognize it immediately. Sometimes it's difficult to count. Here we have 1, 2, 3 B-lines at least, so that's positive. Here we have a bit more difficult, 1, 2, 3, perhaps a 4th B-line, positive for interstitial syndrome in any case. So if we have that on at least 2 quadrants in any hemithorax, we will count that as interstitial syndrome. If you take the abdominal probe, yeah, they look a bit different, but still you can count there are at least 2, 3 B-lines arising. So that's positive for B-lines. Why is that useful? If you have a patient who is in respiratory distress, who is wheezing, and you don't know what is it, use the ultrasound probe. And I think I've seen a lot of patients with pulmonary edema, and I've seen a lot of patients with exacerbated pulmonary disease, exacerbated COPD. And believe me, sometimes I don't know what's the problem of the patient. The patient is coming, they often have comorbidities. So many COPD patients have cardiac failure, and many cardiac failure patients also have a bit of chronic lung disease. And they're coming towards you, and you don't know what it is. In auscultation, at the beginning, pulmonary edema sounds the same as COPD, because you just hear the wheezing when the water is in the interstitium, the bronchi get smaller, so you just hear the wheezing. You don't hear anything like crackles or so. Yeah? So sometimes you can't differentiate it. So the thing to do is just take your probe, put it on the thorax, and if you see not really many B lines. Perhaps there's one B line here, perhaps one here. That's not interstitial syndrome. That patient does not have pulmonary edema. So if you think it's either pulmonary edema or asthma or COPD, that would be bronchial obstruction and not pulmonary edema. If you see this patient with a lot of B lines in any quadrant, every single picture you have a lot of B lines, that would be interstitial syndrome. So if the same patient is wheezing, you would see that's rather pulmonary edema. So there is also the consensus statement, lung ultrasound is superior to chest radiography for ruling in interstitial syndrome. In other words, if you think the patient might have pulmonary edema, it's much easier to take the ultrasound probe and to see if the patient has interstitial syndrome than to see anything on an X-ray. What are the limitations? The problem is B lines are not specific for interstitial syndrome. B lines are specific for there is a problem with fluid air or tissue air interface. Yeah? So that can happen in pneumonia, in ARDS, in fibrosis, as we said, in interstitial syndrome of any reason. So you don't know exactly what it is. You have to see the patient with his clinical condition, and then you will rather see does that clinical picture fit together? Is that really pulmonary edema, or is it a interstitial syndrome of another reason? Yeah. So that was it for lung ultrasound. Any questions? Nothing. Everything clear, or everybody still tilt from the party? No, please. Okay.
I'll hand you the microphone. Okay, the question was, what should be the penetration depth when scanning for B lines?
Well, in fact, you need a bit more than the thoracic wall. I would say the B lines, they always go to the end of the picture. Yeah? So you can take 15, 20 centimeters. It will have the same, you will have the same result as if you take 10 centimeters. Yeah? If it's an obese patient, you will rather do it deeper. If it's a slim patient, like 7 to 10 centimeters will be okay already. Yeah?
You do have a question too? Please.
My question was, can you tell us just briefly, in pneumonia, should we expect a static bronchogram or a dynamic air bronchogram? Or both? Or?
You could expect both. Yeah? You could even see fluid bronchogram, so fluid inside the bronchi, but that's highly suggestive of an obstructive process. So if you see no bronchi inside your consolidation, but just fluid that's sometimes moving a bit, that's suggestive of an obstructive processes. If you have air bronchogram, this could be static or dynamic either. Depends on what's the reason for the pneumonia, in fact. Yeah? So why do we have pneumonia? But as soon as you see the air bronchogram, that nearly excludes atelectasis as the reason. Normal atelectasis does not have air inside.
Another question from Berlin actually came in. I'm just going to read it out loud. How do you avoid mistaking the border of pericardium and pleura for the lung point? By increasing the depth of and looking for myocardium, or by avoiding the area of pernosternal heart views altogether?
That's a very good question. The problem with that lung point is always there are some physiologic lung points in the lung. Yeah? So when the lung ends, you could mistake that for a lung point. It's either here the pericardium, it could be the diaphragm, and it can also be the fissures, because the lung has on the right side 3 lobes, the left side 2 lobes. So even the fissures sometimes can be mistaken as lung points. Yeah? So you just have to see anatomically where you are, and for the question that was asked about the pericardium, watch where your so-called lung point is, and then watch where the heart is. Perhaps you can just rotate the probe and see and make an echocardiogram out of it. So you will see where the ends are, and in your echo you will also see where the lung starts or ends. So if you're not really sure about it, the lung point in this region, I would rather take the other signs. So absence of B lines, abolished lung sliding, to be sure if there's pneumothorax or not.
Okay. Are there any more questions about lung sonography, the audience? No? Thank you so far.
Okay. There's a lot more to talk about lung sonography, but we still have the 2-point leg sonography that we have to care about. So why do we scan the legs for thrombosis? Why do we want to know if a patient has thrombosis? There are two reasons, two situations in emergency medicine when we have to scan the legs. First reason is the leg is swollen. The leg is thick and the patient has pain there. We have to see what's the reason. The second reason is the patient has respiratory distress and we want to know, does he have pulmonary embolism? How can we see pulmonary embolism? We can do a CT scan, we can do a VP scan, okay? It's not very handy. In the emergency department, we just take the ultrasound probe, yeah? We do a scan of the heart. If we have dilated right ventricle, that's a clear sign, yeah? There could be clear sign. It's a clear sign that there could be pulmonary embolism. We can take the probe and watch for small subpleural defects. Dorsobasally, that's the infarctions after the pulmonary embolism, so we also can see it with thoracic sonography, but that's not quite easy to find, and it takes a lot of time. And the third thing is, if we think there is pulmonary embolism and everything fits into the clinical picture, we just look for the vein, for the thrombosis that's causing the pulmonary embolism. And if we find it, we are sure. If we don't find it, well, that's a problem. But it's still the same thing. We just try to rule it in. If we have it, we can be sure that the thrombosis is there. So how do we scan? Usually a scan of the veins of the leg takes a long time. Yeah? You have to scan the whole veins until the muscle veins on the calf. You have to have good experience and you have to have a lot of time. In emergency medicine, that's not so easy. So what can we do? We just do a 2-point scan. And the 2-point scan is quite good at the moment where you have a symptomatic patient. So it's good if you have a patient with a swollen leg. It's not that good if you have a patient with suspicion of pulmonary embolism, and it's not at all good if you have a healthy patient. You don't know if something is happening. Yeah? But as soon as you have a symptomatic patient, just do a 2-point compression ultrasound of the leg veins, and you will know a bit more. What are the 2 points you are scanning? One is here, femoral vein just in the thigh, and the other one is the popliteal vein in the knee. So if you do these 2 points and you see that there's something going on there, you have a positive sign for ruling in the deep vein thrombosis. You don't have to scan the whole leg because it would take too much time. What is compression ultrasound? We take our probe, we visualize the artery and the vein, and then we just put the probe a bit in. We make a bit of compression, and the artery should stay open. The vein should collapse. If the vein does not collapse, it's either that we're not pressing hard enough or that there's something in the vein. The second thing is that if you see some structures inside the vein, what will it be? Most people don't stick anything inside the vein, so if there is something in the vein, it will mostly be a thrombus. So that's the 2 things you can see. The one thing is here, the vein is collapsible, there's no thrombosis. If it's not collapsible and something is inside, that's highly suggestive of thrombosis. Which probe do you use in this case? The best thing is to use the linear probe because you need the high resolution in the near field. Sometimes in very obese patients, it can be good to use the abdominal probe. So what do we find? Normally, the vein is compressible, the lumen should be free, and if you compress distally, there should be a flow acceleration if you're using Doppler ultrasound. So that's what it looks like. Femoral vein, this is the artery, this is the vein, and if you compress it, should fully collapse. If you have color Doppler inside, It's the same thing. The artery is not fully compressible, the vein is fully compressible. If you see something inside, something can't really differentiate, just put some pressure on it. If you put pressure on it and nothing happens, that's highly suggestive of thrombosis. The same thing here. I think you see something here inside the vein. These are the arteries, two arteries, so the superficial and the deep venal artery, femoral artery, and here in the vein you don't see anything, you can't compress it. You see perhaps a bit of a structure that's highly suggestive of thrombosis. The same picture again. So if you see it somewhere, you should already know what's happening, what's going on. We tried it now? Okay. Just try it on a live demonstration now. If we see something. So, ja. Fangen wir beim Bein an jetzt. Mal Vene und dann den Rest. So. So we just take the probe. We look for the vessels. So, wo haben wir da? Fokus haben wir auch irgendwo. Fokus. So, we see the vessels. We don't know which vessel is which one. Just put the colored up lane. And we compress. And we see the vein. See the way. Do we have a point there? The vein is fully compressible. It's echo-free lumen, fully compressible. It's classical sign. There's no deep vein thrombosis at that point. And then we just follow a bit down. And we compress it, and still it's fully compressible. There's no thrombosis here. You could follow the whole leg. If you say I don't have time for that, we just go into the popliteal region. It's a bit weg. So. With the vein dorsally to the artery. And if we compress, there's only the artery, and now we have the vein again. So the vein can be fully compressed, and the artery stays open. Okay. Okay, schauen wir dann oben auch noch. So that was the deep vein thrombosis. If the patient has severe distress and they think that could be pulmonary embolism, the thing we should do before is, of course, make a quick echo. For chamber view. ausatmen. Okay. So we see there's no right heart dilatation. You can also look at the parasternal long axis. Then turn to the short axis. There's no D-shaped ventricle. Well, not quite a good view. Okay. So we see the septum is not flattened. And the third thing we could do, mal aufsitzen und hinten kurz frei machen. Take the third probe. And we scan for subpleural defects. So there's the lung surface. We see here the lung sliding. Below there are just artifacts, and the so-called pleural line is quite clear, no defects. So if we scan the whole posterolateral region on the dorsum, we don't see any defects. There's no sign suggestive of pulmonary embolism. Of course, we cannot rule out every. Thank you. Of course, we cannot rule out pulmonary embolism totally with that, but if the patient has absolutely no signs of anything, we have to think what's the most probable pathology. If we still think it's pulmonary embolism, we send him to the CT scanner. If we already found something with that exam, we can save a lot of time and money. Okay, thank you. So, one more thing for the exam of the veins. Thank you. No, sorry. No, das sind wir jetzt rausgerutscht. Okay. For the exam of the veins, you cannot scan the pelvic veins, yeah, because you can, sometimes you can, but it's quite difficult to scan the veins in the pelvis. So if you think there might be pelvic thrombosis, you can just put a collar Doppler in your femoral vein, and if there are no respiratory modulations, there are normal respiratory modulations because the intrathoracic pressure is putting pressure on the caval vein, and that's it's going down till the pelvis. Yeah? If you don't see any respiratory modulation, like we do here, that's suggestive of pelvic thrombosis. So if you're not quite sure, you say perhaps there's something, just put your Doppler mode in and watch for the respiratory modulation in the femoral vein. So, any more questions? Everything okay? Everything clear? So, my last picture is a picture from Simon Orlob, who is just one of the big heads of this summer school or late summer school. On the first day, sorry, question?
Yeah, if there's a thrombosis, do I have to worry about pressing on it? Maybe you could
Yeah.
repeat the question for my
Yeah, the question was if
Yeah.
there's a thrombosis, does the examiner has to worry when pressing on it?
There have been some interesting work on it. There's no evidence that pulmonary embolism was caused by the compression ultrasound. Yeah? So usually we don't have to worry. As soon as you see something, you can stop pressing, but don't have to worry for it. Yeah?
There have been more questions on the topic of lung sonography, if I might
Yeah.
just insert them here. From Zurich,
Yeah.
they asked, does the number of B lines vary when using either a convex array or a cardiac probe?
It does slightly vary, but with both probes, you can rule in interstitial syndrome as long as you have 3 B lines in one picture. Yeah? So most of the studies have been conducted with the echo probe. So you should rather use the echo probe if you start scanning for interstitial syndrome. But if you compare it, you can just use the other probe again. There won't be much variation. And for ruling in the syndrome, it's okay. And also for the follow-up, if you continue then and look if it's getting better or worse, you can use any probe.
Another one. I think this is referring to your slide where you showed us the rib fracture.
Yeah.
And the question is, how come the lung is visible behind a rib fracture?
Good question. There's somebody who is taking care. Somebody was really watching my presentation, apparently.
Yeah, they were all actually so excited. We had great feedback already.
Okay, yeah. That's the picture, yeah. And you are right. Behind the rib, you couldn't see the lung. That's why I rotated a bit out. Here you see the rib margin quite well, and you don't see the lung sliding behind. Here's the fracture, and here you can't really see the rib anymore. So I'm a bit at the lower end of the rib, and I don't see the rib anymore in the picture. So then I can see the lung sliding here. In fact, yeah, I don't see what's going on behind the rib. The only thing where I can see something, what's going on behind, is if you are on the cartilage, so it's perhaps in children and young people. But as you pointed out rightly in this question, you couldn't see the lung moving behind the rib. So you have to rotate a bit your probe, and then you see what's going on behind.
Thank you so much.
Okay. So we're nearly done. So, picture from Simon, as I told you, on the first day, you were told the discussions is the ultrasound, the stethoscope of the future, and there were perhaps some people who were not so convinced that ultrasound will replace the stethoscope. Me either. As a pulmonologist, I use the stethoscope every day, and I see that the stethoscope is underused. But what is much more underused is the ultrasound probe, and I think you should use both. You should use your stethoscope, you should use your clinical judgment, and you absolutely need at the same place when assessing your patient. It must not be in the emergency department. Also, if you're on a regular ward, if you're doing your ward rounds, I think the ultrasound has a future there. And in my intensive care unit, I'm using the stethoscope every day for every patient, but I'm using the ultrasound nearly every day for nearly every patient. And I think that's the way to go in the future. Thank you.
We do have a little thank you gesture for you. Thank you for coming once again. And as I said, the feedback has been so wonderful via the live stream, and everybody, I think, agrees that this was a very comprehensive overview of lung sonography and DVT. Thank you so much.
Thank you very much.
Okay, so I think, we're very good on time. We're going to take a 10-minute break, and we're going to set up everything for the video conference, and then we hope that everything works out just fine. So see you in a bit.